Okay, welcome to this Bristol University Press Policy Press book launch for Professor Priscilla Alderson's book, Critical Realism for Health and Illness Research, A Practical Introduction. This book has come out of a doctoral study program and reading program that has been running at the Institute of Education, University College London since 2006, when the founder of Critical Realism, Professor Roy Bhaskar, joined the IOE, Institute of Education faculty, and began this program of research. Sadly, Roy passed away in November 2014, and Priscilla has since then run a very successful program for doctoral researchers and written several books on childhood and education and using critical realism. We have with us today 4 colleagues who are very practiced critical realist scholars who are going to say a little bit about their perspective on critical realism and why they think it's important. Professor Douglas Porpora from Drexel University in Philadelphia, Dr. Rosa Mendizabal, who's at the UCL IOE and works with Professor Priscilla Alderson on childhood permission for operations, severe operations conducted in the London hospitals. And Brenda Hayanga, who I believe is at Sussex University and has used critical realism in her own PhD work and postdoc work. So our order is that Douglas is going to introduce some points about critical realism and his background on the subject. And then Priscilla is going to talk a little bit about the book and why she thinks critical realism is so relevant. Rosa is going to use her experience of applying critical realism in her research area, and Brenda the same. And we're going to talk for about 40 minutes, and then we're going to take questions from the audience that should appear in the question and answer facility in the Zoom. So please put your questions that you want the panel to address after their presentations. And with that, I'll hand over to Douglas to make his input, please.
Okay, thanks, Chris. I guess I am practiced in critical realism. I'm the current president of the International Association of Critical Realism. And I'm very honored to be here celebrating the launch of Priscilla Alderson's new book. Priscilla has been a prolific and important author of books on children, their rights, their well-being, and their specific treatment by healthcare institutions. And Priscilla has also written on the application of critical realism to childhood studies. Now in her new book, she's writing about the application of critical realism to healthcare in general. Priscilla's new book, Critical Realism for Health and Illness Research, is important both for critical realism and for health and illness research. From an academic or philosophical perspective, it's important for the appreciation of critical realism's breadth that Priscilla is able to show how helpful critical realism is to yet another endeavor of research. Critical realism is a theoretical perspective and an approach to research, which has already been increasingly adopted in such fields as anthropology, sociology, psychology, and economics. In contrast, like business, where critical realism is also being adopted, health and illness research is a more directly practical field. And Priscilla's book is entitled A Practical Introduction. Thus, as important as Priscilla's book is for an appreciation of critical realism's breadth, as a practical matter, it's actually more important that it shows the benefits of critical realism to research in health and illness. Well, I'm going to touch on some of the ways in which critical realist insights are important to that area. My role in this launch is to provide some background on the importance of critical realism more generally. As you heard Chris say, critical realism has been closely associated with the work of Roy Bhaskar, who worked alongside Priscilla. But critical realism actually emerged in the 1980s from a whole community of progressive scholars that included sociologists like Andrew Sayer and Margaret Archer, and economists like Tony Lawson and Steve Fleetwood. Critical realism is a philosophy of science. Philosophy of science can be defined in different ways, but I'm going to try and make it simple. Any enterprise in health research or anything else is an attempt to figure out what's going on. Sometimes we're just trying to describe reality. How many people in a population we might want to know are infected by COVID. Other times, however, we ask important questions about causality. How, for example, is the virus spread? Is it more by air or by touch? When we begin to ask these questions, we approach them with certain presuppositions. If we're talking about causality, for example, what do we even mean by causality? What do you mean? Similarly, if we're just trying to describe reality, what do we mean by reality? Again, I could ask what you mean. These questions have different answers, and those answers are our presuppositions. Together, they form a philosophy of science. Researchers generally approach their study without thinking about their presuppositions, but it makes a big difference to their research what their presuppositions are. Suppose, for example, your basic philosophy is the post-structuralism that comes out of France, the perspective of Jacques Derrida or Michel Foucault, for example. Then your view is that all is discourse. That is, what is real is what we consider real, what we talk about as being real. As Derrida famously put it, there's no reality outside the text. There's nothing outside the text. No reality outside our discourse. Even our scientific truths are like anything else, social constructions. If you are a researcher with this view, you look only at how people are talking and not at the objective reality they're talking about, because you don't believe there is any reality beyond how they talk about what they say reality is. And if they say different things, there's no way to say who's right. It's hard to make a case for anything on this view, that there's climate change, that there's structural racism, that COVID is more serious than the flu. Post-structuralism, in short, is aligned with the whole disastrous post-truth moment in which we now find ourselves. Against post-structuralism or social constructionism, critical realism affirms an ontologically objective reality independent of our talk about it, a reality that can be ascertained with enough certainty for us to say that some talk is true and that some talk is not true. That affirmation of truthfulness is crucial if we were to act on one set of beliefs rather than another. Do we wear a mask or do we not wear a mask? Critical realism affirms not just an ontologically objective reality independent of our thoughts or our talk about it, but it also specifically affirms social realities beyond individual people and their actions. Critical realism thus goes beyond methodological individualism. Against methodological individualism, critical realism affirms social structures that underlie, among other things, epidemiology and public health. In my country, the COVID pandemic has hit racial minorities with particular severity. Why is that? Because there is a consequential pattern of structural racism that endures even beyond the racist attitudes of individuals. And as you've noticed, probably, we have plenty of that too. Roy Bhaskar's four-planar social being, which Priscilla discusses in her books, and I guess Brenda's going to be speaking to, sensitizes researchers to material to material factors in social life beyond those to which other perspectives draw attention. The dominant approach to research in the social sciences is called positivism, against which critical realism again offers a distinctly different set of presuppositions. For one thing, positivism presupposes a sharp distinction between facts and values, counseling researchers to stick to the facts and leave their values behind. Critical realism argues against this posture. Critical realism argues that facts and values are often inseparable, and that to attempt to separate them injures the research process. Is the existence of racism in a society a fact or a value? Well, it's both. We think of racism as something bad, but whether it obtains in a particular society is a fact, a moral fact. Health, similarly, as Priscilla says in her book, is something we value. But again, whether or not health obtains somewhere is again a fact. By denying the separation between facts and values, critical realism encompasses the research we actually do and the research that matters doing. Mostly, though, positivism understands causality as law-like connections among events. If you understand causality as law-like regularities, then your research will exclusively be seeking these realities and be only statistical. Description, however, even mere description, is tremendously important to science. There were great scientific triumphs when we definitively described the structure of the atom or DNA. Thus, in contrast with positivism, critical realism does not think of causality in terms of regularities connecting events, but instead of the mechanisms that actually explain why those regularities obtain. As mechanisms need description, critical realism promotes research approaches like ethnography that are not necessarily statistical. It thus broadens our understanding of what the research process should be and needs to be. Priscilla's book introduces these insights specifically to research on health and illness, and I wish it every success in promoting better presuppositions in that field as well. Thank you. You're muted, Chris.
Thank you very much, Doug, for that overview and introduction to critical realism and why it's relevant and important. I think we'll ask Priscilla now to make an input and talk a little bit about the origin of the book and why it's been developed and whatever you want to add to what Doug says about the value and importance of critical realism at this moment. Over to you, Priscilla.
Thank you. I'd like to thank everyone who's attending this launch and the other speakers. It's great to have Douglas from the USA talking to us, especially on this rather special day for your country. And I'd like to thank Policy Press also for arranging the event, and people who've sent kind messages about the book. The ones I'm most grateful for are when people say they found it clear and helpful. They were my two first aims. So, in public and policy debate about COVID and the climate crisis, sadly, there's often a deafening silence from sociology. There are no sociologists, for example, on the government's SAGE committee. The new president of the Academy of Social Science said this week that we need social science in public debate, but what a sad admission to make, that it isn't there. And this month, at the British Sociological Association annual conference, debate about public sociology was about the problems, as to what and how sociology is so excluded, problems and remedies. But as usual in sociology, but this is where critical realism comes in, they missed out causes. Why is sociology so silenced and excluded from public debate? Now, I'm going to suggest 6 reasons, and I'm going to briefly say how critical realism helps to address them, and I describe more about that in my book. The first is that sociologists, and a lot of this is picking up themes that Douglas has raised, that sociologists disagree with one another about how to do their work. And if we disagree with one another, how can we expect other people to respect us? Now, sociology, I think, helps because it brings in the positivists, the interpretivists, even the postmodernists, and puts all their work into the larger framework to show that these different approaches can be all complementary, like different pieces in the jigsaw, and critical realism showing something of the picture on the lid, though of course we'll never complete that picture. The second, and Rosa's going to talk a little bit more about the larger picture of reality. The second problem is the idea that science can only be factual and positivist. But if it was all evidence-based, then physics would not have gravity and biology would not have the theory of evolution. Theories are so tremendously important to science, as critical realism reminds us. The third problem is the myth that all the disciplines are best being separate, atomized, arcane even. So from neuropsychology to economics, criminology to nutrition, each specialist speaks in their own sphere. Again, critical realism is so helpful here in drawing them all together, showing how they interrelate in social life. Then there's the myth, as Douglas has told us, that social science must be value-free and non-political. And sadly, that ends up with ignoring the latent values in all social life and ending up siding with the powerful. There's quite a lot in the book about how a lot of evidence-based social research on health backs powerful forces and is not that helpful to disadvantaged individuals. And then we suggest how this could change. Fifth, there's confusion about relations between individual agents and social structures. There may be blurring of them, there may be very strong structures, or there may be seemingly strong agents. Critical realism analyzes these different approaches and then suggests a much more interesting interactive one, a dynamic one of process and change. And the sixth one, there are many other causes, but these are just six. The sixth one is that social science is so much stuck in the past. A lot of our reports are of evidence we have collected many years ago. At the conference, someone talked about we need slow sociology. We'll have to wait until the pandemic is over before we can begin to do the sociology about it. Oh, why can't we be practical and present and also forward-looking? And we could do that by looking back at the history, the long history of pandemics and the common themes and threads throughout history that we could pick up and analyze today. We also need forward-looking sociology that looks about potential, possibilities, the future, and critical realism offers marvelous ideas about this, looking at absence, emergence, and transformative change. The final chapter in the book is about this. So, having said that the problems, I hope the causes, another main contribution of critical realism in drawing all these different disciplines together is to look at methods of interdisciplinary research, which we're beginning to see is so urgently needed in the climate crisis and could be more so in the COVID debates. So the book is about all these challenges. As Chris has mentioned, it is based on the course that Roy started in 2006 and which Chris attended in that year. So there's the historical link. But since Roy very sadly has died, the course has changed quite a lot over the last 7 years, with students contributing a lot more about how they apply critical realism to their work and making the course very practical. There's great demand around the world for critical realism courses. The demand far exceeds the supply. And I hope the book will encourage people to think about forming courses on critical realism and discussion groups. Each chapter ends with discussion questions so that we can bring forward a whole new generation of social researchers and academics using critical realism, and also all social science students who could apply critical realism in their public and their private lives, I hope.
Thank you, Priscilla, for that very informative, exciting, motivating input about why we should read your book and what its relevance is to social science researchers. There will be some questions from the audience that are being put into the Q&A, which we will address once the speakers on the panel have made their inputs. I'd just like to now move to Brenda Hayanga, who is at the University of Sussex and who uses critical realism in her own research. And Brenda, would you like to tell us one of the ways or some of the ways in which you use CR in your own work, please?
Yeah, sure. So I'm going to share my screen from now on. So do let me know if you can see the slides that I'm going to be putting up. Okay, 1 second. Right, it appears that screen sharing isn't enabled for some reason.
Are you a co-host?
I should be a co-host. All right, I think it's been enabled now. All right, so we're good to go. I will share my screen. All right, can everybody see the screens now? Just give me a thumbs up if you can. Thank you. All right, so as Chris has introduced me, my name is Brenda Hayanga, and I'm based at the University of Sussex. I'm a research fellow there, and I'm currently looking at a project that looks at ethnic inequalities in healthcare and care quality amongst people with multiple conditions. So thank you so much, Priscilla, for inviting me to this particular event. I was first introduced to critical realism as a doctoral student at UCL at the Institute of Education, and I attended the critical realism reading groups that Priscilla was talking about and that this book is actually based on. So I'm going to be illustrating to you how you can apply one of the core concepts of critical realism, which is the 4 planes of social being, and how this can be applied to health and illness research. I'm going to be focusing on social isolation and loneliness, which is part of the project that I did for my PhD at UCL. So just before I jump into the 4 planes, I'll just give you a bit of information about my research on social isolation and loneliness, just to give you some context. I was assessing the effectiveness and the suitability of social isolation and loneliness interventions for people from minoritized ethnic groups who are living in the UK. When I refer to minoritized ethnic groups, I'm talking about individuals who don't self-identify as belonging to the white majority ethnic group. Many of you may know, or you may not know, that social isolation and loneliness are a public health concern. They impact on our health and our well-being and a quality of care. And research has actually shown that older minoritized people, when we compare them to older white people, and they tend to be at risk of social isolation and loneliness. There's studies that have shown that they experience higher levels of loneliness compared to the older white people. However, this research in this area is actually not that great. In fact, when I was starting my research, the area was quite sparse, and we didn't even know whether there were any interventions that were effective for older minoritized people in this area. So this is where my research came in. I wanted to address this gap, and I adopted a mixed methods research design that I conducted in 4 different phases. And in one of those phases, I interviewed 10 older people. I carried out 10 in-depth interviews, asking about their social networks in order to try and find out which processes were led to loneliness and which processes were protective of loneliness. So let's move on to the 4 planes of social being, and I'll be able to illustrate how the 4 planes actually helped me to try and pick out this complexity of social isolation and loneliness. So the 4 planes of social being, which is covered in chapter 5 of Priscilla's book, it's actually a core concept of critical realism. It posits that social life is actually simultaneously occurs at 4 different planes. This is the material transactions with nature, social interactions between people, the social structure, and the embodied personality. These 4 planes, they cover all aspects of human life, and they range from the personal to the international, the local to the global, and they need to be understood in relation to each other. So they both shape each other through both time, space, history, as well as nature. The core concept of the 4 planes is actually quite interesting for researchers to use, because it can help you want to organize your data as well as to analyze the data that you have. I'll just show you an illustration with a bit of the data from my own research on social isolation and loneliness. We'll start with the first plane. So the first plane is the material transactions of nature. It posits that all social events and actions, they need to be captured in the material aspects in terms of our transactions with nature. When we're referring to nature, it's not just referring to the natural world, but we can also look at the built environment. Researchers here are encouraged to look at participants' physical presence, their embodied needs and activities, and how they interact with their environment to place them in positions of, in my case, social isolation and loneliness. So when I applied this to the interviews that I did, I identified things like some participants who were living alone, some who were widowed and had health issues. And these are well documented in the literature that these processes can lead to social isolation and loneliness. But what this plane actually brought out, it's something that I hadn't picked out, is how they interact with nature. And when I was going through one of the participants' transcripts, this is Mrs. Kuboni's excerpt here, that talks about how she interacts with her environment. She's one who finds, going out to feed the ducks and to give the, birds bread very therapeutic. But we need to consider that she was a late life migrant and she came from a very hot country. She wasn't born in the UK. And she indicated that things like the weather will affect her going out. And so I was forced to think about how cold weather can impact on people's processes and social interaction, because when it's cold, then she doesn't go out, and this places her at the risk of social isolation and loneliness. So the next plane is the social interactions between people. At this particular plane, all social events and actions, they need to be captured in their relational aspect in terms of our transactions with other human beings. So it speaks to how we interact with each other and what we do together. So if you're applying this plane to your research, in my case, I was considering how the participants were relating to the people from their social networks. So friends, families, neighbors, and colleagues. And what I identified was that there were a whole host of different networks. Some people who had diverse networks tended to have, lots of friends, family, and they had lots of interactions. And these people were protected from isolation and loneliness. On the other hand, those who had restricted networks tended to have fewer friends, and then this placed them in positions of isolation and loneliness. However, I must note that having a small network doesn't necessarily mean that you're going to be to feel lonely. Loneliness is a very subjective issue, and we'll come back to that in the 4th plane, which is related to the second plane. But also at this particular plane, we're advised to consider things that hinder our interactions with our social network. I've picked this excerpt here from a woman who was in her 80s. She was single and she lived alone, and her social network was basically formed of her friends. But she did want to keep in touch with her friends and her family members. But we've got this notion of busyness, and people are very busy and they don't have time. And she also admitted that she was busy. For some people, it's okay, and they might have other avenues to be able to link up with their social networks. But for other people, this might foster feelings of dissatisfaction, and then this can then lead to feelings of loneliness for some people. So in this plane as well, we're encouraged to consider how certain structures that positively influence our relationships. For my research, I identified things like the free bus travel for people who are age 60 and over in the UK. Things like technology that have been very, very, very relevant for, I suppose, us living in the pandemic now. And I did this research prior to the pandemic, so community groups where people come together to be able to share ideas and just interact and mingle were quite important. This excerpt here is from a participant who was a carer. She's a sole carer of her husband who had a long-term condition. And she tended to go, once in a while to these community groups where she could meet people. They would play games and they would have, they would chat. And you can see how this can then alleviate her isolation if she's just by herself with caring duties. So these are some of the factors that you would consider in this plane. I'll move on to the third plane, which covers social structure. So the third plane refers to the structures of the social institutions that participants engage with. And we know that these social institutions, they influence how we interact with each other. So at this plane, if you were looking at it, for me, I was in my research on isolation and loneliness, I was considering the dynamics of power and how they influence our actions and our freedoms. So for what I did identify in the interviews was that factors like the economic conditions, so things like the recession, can then impact on people's financial ability, and this then spelled out whether they can interact with others or not. If we also look at policies that maybe are adopted to deal with the economic conditions, we might have austerity measures where governments might even shut down services for older people in an attempt to save money, and then this then influences older people's ability to meet up and interact. I put sexism there just because it was relevant in terms of the participants that I interviewed. The women tended to have these caring duties, and caring, if you like, can be such a gendered activity. I do know that men can be involved in caring, but in this case, some of the women are indicating that they're busy babysitting, their friends are busy babysitting, so they don't have that opportunity for them to have the peer interaction, which can then lead them to this position of feeling isolated and lonely. The final plane, which is the embodied personality, and this plane refers to how personality can be stratified. We've got personal views, people's experiences, people's values, and the identities. This plane is very much interlinked with the other planes I was indicating before, and I'll just illustrate how this is the case. So in this plane, as I went in, I was considering people's personalities, their coping strategies, and the actions that they take to reduce isolation and the vulnerability. And here we found that participants, let's say for instance those who lived alone and those who had restricted networks, some of them were actually forcing themselves to go out every single day to be able to find something to do and get out of the house and not be isolated, and to be able to even chance bumping into anybody. Some of them belonged to faith groups and they had that as their source of support. And many of the participants who were actually identified themselves as not being lonely or isolated tended to have a lot of hobbies to keep them busy. And here I've got an excerpt from Mr. Bilal, who was one of the people who didn't mind his own company. He did a lot of golfing before he retired, and after retirement, he indicated that yeah, he does play, but not just as much. But he tended to read books, and he was happy with that. He wasn't afraid of his own company. So we can see here how this then can help him to, I suppose, fend off feelings of isolation and loneliness. Now that's just a whistle-stop tour of the 4 planes of social being. I would urge you to get the book and see the other examples that Priscilla's given in the book that are very relevant for health and illness research. But just as a takeaway message, I just wanted to leave you with 3 points. The 4 planes, when I was using them, after you're aware of what each plane entails and how they all intersect, then it's easily applicable. It provides you with a structured approach to how you can analyze your data. You don't have to have collected your data with the 4 planes of social being in mind to be able to use this. So if you have data sitting around, you can go back and revisit it and to be able to look at what it can bring out. Finally, it encourages this multi-level analysis from the micro level to the meso level and then the macro level. And this is really important, especially because in loneliness, when we're talking about things like isolation and loneliness, people tend to focus on the micro level. Oh, do you have enough friends? Are you going out? But if we ignore the wider processes, we've talked about the economic conditions. We've talked about, I know I didn't really talk much about it, but the cultural values, individualistic cultures, as well, then if we ignore this, then we're only going to come up with interventions that may, one, be ineffective or, at worst, be harmful. So I will leave it here and I will hand back to the room and yeah.
Thank you very much, Brenda, for a very clear illustration of how that particular framework be applied and I hope that came over. So thank you, Brenda. Pass on over to you, Rosa, to input on how you use critical realism in your work.
Thank you. Can you hear me well? Yeah, okay. I'm going to share my screen as well. Okay. So again, thank you very much for having me here, and thank you, Priscilla, for inviting me. It's a real honor to be part of this group of panelists, and thank you so much for introducing me to critical realism. I was a PhD student at UCL Institute of Education a few years ago, and I was really lucky to have Priscilla as my supervisor. And I was also very lucky to attend some of Roy's seminars, which were really helpful to introduce me to what I now consider is a really valuable tool to do research, and that I have continued to do as a postgraduate researcher. I'm going to talk a little bit about how I use critical realism for my PhD research on looking at the organization of neonatal intensive care units in Mexico. And just to set this study in context, if we think about the latest 12 months, we all have heard heartbreaking stories of people who have to go into hospital and they have to go alone and their family members cannot be with them. And we have all been saddened to hear that this separation continues for days, weeks, or months. When I did my study in these hospitals in Mexico, there was no COVID-19, but there was separation, and this has been a reality for newborn babies and parents around the world for many years, because parents are still very much excluded from being with their babies when the babies are admitted into hospital in critical care. And this has very deep implications for families and for the life of these babies into adulthood. I was also lucky to understand more about family-centered care and baby-led care when I came to live to London, and I worked in a hospital who was leading in this type of care, baby-led care. And just to describe briefly, infant and family-centered developmental care aims to improve infant and parental long-term health by acknowledging the importance of parental involvement and individualized care based on infant behavior. And I am highlighting infant behavior here because I'm going to, in the next couple of slides, I'm going to be talking a bit more about the importance of listening to babies and understanding their cues. And these programs accept that family access and involving parents in the care of their infant is also a matter of ethics and of human rights. And there is still a lot of reluctance to allow parents to care for their babies while their babies are in hospitals. And that was the reality of the hospitals where I did my research. Even though there is evidence about family-centered care, it's still very difficult for clinicians to understand how this evidence can be implemented in practice. And that has caused many healthcare professionals around the world to still struggle to implement the principles of family-centered care in practice. And the main problems of that is that life-saving measures like kangaroo mother care or skin care, where the parents hold their baby on their chest, are not being implemented in the hospitals. And this is only increasing with the COVID-19 pandemic. And also breastfeeding practices are not being followed in many of these hospitals, even though we know breastfeeding is another very important life-saving practice. So I asked, why are preterm babies in Mexican hospitals cared for as they are? And what I mean is, why cannot we see parents in that unit? Why are babies being isolated and separated and denied from the love of their parents and the care of their parents? So I did an ethnographic study. I talked to a lot of people, parents and healthcare professionals. I interviewed them. I administered a survey. I also observed consistently the care of babies during 11 months into neonatal units. I systematically measured noise levels and examined documents. I mapped people movements around the unit. And from the critical realism perspective, I also attended at the social, political, cultural, and economic context at the time. And as a PhD student, I came up with a very fancy diagram. But today, why I wanted to show you this diagram is because this is what came up from my repeated observations during 11 months. So if you imagine this to be the neonatal intensive care unit in the hospital where babies are cared for, what I am arguing is that what I systematically recorded is clinicians approaching babies, and rather than looking at the baby, referring first to the monitor, which I have denoted them with an M, and the clinical chart, and taking that as the reality of the baby and making decisions on the care provided to the baby based on those readings. And in critical realism, that is called the epistemic fallacy. And it is when we collapse our knowing and thinking into being, and being here is the real baby. So what developmental and family-centered care advocate for is that clinicians need to observe babies, listen to babies, understand their cues, and plan care based on those cues. When we continue to fall into the epistemic fallacy, to collapse knowing into being, then individualized care cannot be implemented, and routine care will continue to be practiced in the hospitals. What I have also in the diagram is the parents who could only come in for half an hour a day to see their babies. But in that half an hour, the only thing they did was to observe, and they, in the interviews and in my conversations with them, I registered that they were very knowledgeable about their babies just for observing them for half an hour. And then the dotted lines here denote the communication within the unit. And unfortunately, that communication about the baby and the cares for the baby went among the doctors that I denote with the D, the nurses with the N, and outsider healthcare professionals like the psychologist, nutritionist, social worker, but not, the parents did not feedback any information about their knowledge of the baby. And the arrows also denote that the readings from the monitors and from the clinical charts were, and the information about the baby were given to parents, but information was not relayed back from parents to clinicians. So communication ended up being poor in these hospitals. And in the 3 levels of reality that Priscilla describes at the beginning of the book, we can see that at the empirical level, which is the level in which we are able to observe and how we see and describe events, clinicians were very much aware about the benefits of programs that involve parents and aimed for what we can see in this image, which is, for example, closeness between parents and babies and breastfeeding. But the reality of the hospital was in reality was difficult to implement this, and one of the reasons was because on the actual level, clinicians wanted to protect babies from outsiders, and in that sense from parents, thinking that by excluding parents, they didn't bring germs into the unit and protected the vulnerable babies. These charts are my mapping of people in the unit, and what shows here is that cross-infection did not come from the parents. And when I present these mappings, I always say that I don't intend this as a criticism for the doctors and the nurses in these hospitals, who I ended up admiring for the hard work they did and for everything they did with the very scarce resources they had in this unit. It is just to say that the argument that parents should be excluded from the unit to protect babies doesn't hold if it is just to prevent cross-infection. And more importantly, that my last, in explaining these maps, I show a mother coming into the unit, washing her hands, seeing her baby for half an hour, not touching anything that was not related to the immediate space of the baby, and leaving the unit. And then the next mapping is 3 healthcare professionals caring for babies. So we have a nurse, a cardiologist, and the consultant. And then my last mapping is the priest, the Catholic priest, coming to anoint oil on every baby's forehead without sanitizing his hands in between babies. And an event that was not challenged and was on the opposite welcomed by clinicians, because they thought spirituality was very important for the families, the babies, and the healthcare professionals in the unit. And at the next level of reality, well, we have all the underlying issues at the political, economical, and cultural level that I feel caused babies to be cared for in the way they did. And I don't have time to go into all of them, but what I would say is very powerful political forces, such as the divide between the private and the public healthcare provision, that ended up showing healthcare provision as a commodity that was more valuable when people paid for it. At the economic level, not only the scarcity of resources, but also a poorly funded healthcare system that also stigmatized the poorest people who accessed this type of social security called people's healthcare insurance. And at the cultural level, many prejudices of social class, of gender, ethnicity, the influences of religion, but also a very important event that happens in many countries and is a real problem in Latin America, which is healthcare professionals' attitudes towards women in labor, called obstetric violence, that I argue is extended to the babies in the neonatal units. And that needs to be looked at, and that parents' presence could help protect. And I argue this results in inequality in healthcare provision that limits opportunities for many parents to engage in potentially life-saving and developmentally significant interventions, such as breastfeeding and kangaroo care, and denies babies the enjoyment of the highest attainable standards of care in healthcare. And I am going to leave it there.
Thank you, Rosa, for illustrating your application of basic critical realist ideas, introducing us to ideas like the epistemic fallacy and how that shows itself in reality, and the stratification of reality into the three layers of the empirical, the actual, and the real. Those are the kind of working concepts that critical realists use, and were illustrated very well on with Brenda's application of the four phases of social, the four-plane social being, the framework of analysis that you use. We have some questions from our audience and some comments that I'd like to relay to our panel. The first question that someone asked was,
Chris, there's something off with your sound. I thought it was just me, but I saw somebody say something. So you're coming across very, it's hard to understand what you're saying.
Sorry, I've been having some problems with my audio on this machine. So if you can read the question and answers, can you see that? The one panelist has asked, where can they get doctoral training? Sorry.
Chris, we are sorry, but we just can't hear what you're saying. So would it be an idea if we just look at the Q&As?
Yes,
That'd be all right. I hope you don't mind. One question was, I hope I'm clear, am I?
Yes, you are.
All right,
and
one question was, do we know of any doctoral training courses on critical realism? I'm sorry, I don't know any. I have heard that at Rhodes University in South Africa, critical realism is the specialty of choice among the students. And I do know there's some kind of center at Yale University. We are very, very much hoping to set up a course at UCL, but it's going to take a couple of years at least. If anybody knows of that, we would be so grateful if you'd let us know, then we can publicize it. The other thing I suggest is that anyone who's interested in studying critical realism, say for their PhD, writes to the head of the doctoral school of their university and says, can you put me in touch with a supervisor who knows about critical realism? So at least one of your supervisors would be able to help you. And that's another way we can build up knowledge. The other question was about Professor James, I'm afraid I don't know about his work, but it did say it's about realism. And I would say in the first couple of chapters in my book, I do look at realist evaluation and Pawson's work and compare that with critical realism, looking at the overlaps and differences. Would other people like to comment on, do you know of any courses, Douglas?
So I don't know, there's a program in critical realism, like a graduate program in critical realism, because critical realism is, it's a school of philosophy, and it would be like having a graduate program in positivism or a graduate program in post-structuralism. So you're generally going to be within a department like English, literature, or social sciences that has a critical realist orientation rather than a program in critical realism per se. And I don't know I don't know this Joseph Maxwell's work, so I can't comment on that. I see that there's a question about the concept of truth is evolutionary in critical realism. Do you know specifically what that, does any of you guys know specifically what that means? I could guess at what it means, but.
You want to have a guess?
Okay, well, so I think in contrast with like post-structuralism and social constructionism, we critical realists think, because we believe in an objective reality, that there's a reality out there, and that when our claims or descriptions correspond to that reality, we have the truth, which doesn't mean that in any particular case, any of us has the truth, and that we don't get at the truth. We get at the truth by arguing with each other, considering different points of view, revising what we think. And so in that sense, we're on the road to truth. Some truths are very simple, like whether there are 5 people, you're looking at 5 people in front of you. Truths like whether there's climate change or whether the vaccines are working effectively, they're a little bit more difficult to ascertain. So the fact that critical realism affirms a notion of truth doesn't mean that any of us on any particular case is in possession of the truth.
Yeah, could I chip in here and say that I'm really interested in truth and critical realism, and and also I'm sure Chris probably thanked Rosa and Brenda, and I would like to put on record I'm so grateful to them, because they showed the real relevance of critical realism to doctoral studies. And I hadn't realized, but now Rosa is at the beginning of life and Brenda is towards the end of life, and that's another way in which critical realism is so broad ranging. Rosa was saying that the reality and truth of the babies was partly in the empirical way people thought and talked about the babies, or didn't. The actual truth about the babies is their actual bodies, their actual illness, their treatment, the true realities. But much deeper are the underlying truths that are causal, often invisible. There are the motives and intentions of all the staff in the unit. They meant to do their best for the babies, but they were constrained by deeper powers of politics, economics, class, and so on. These truths were having huge influence, truths and mistruths. And also there was the truth of the parents' love for their babies, and their relationship with the babies and their future. So that although a lot of people say, oh, there isn't a truth, or there are lots of truths, you could say that underlying all this, truth is a great force like gravity, and it's undeniable, indestructible, it's there. We can't understand or know it at all fully, and it's rather like a compass point, in that all the time we're testing the truth of things. Like when we walk downstairs, are they made of wood or stone and will hold us, or are they made of treacle? Turn on a tap, is it water or gin that comes out? We go with all these truths in our daily lives all the time, or we would just be bewildered and confused. And so underneath this is the truth, the true reality that we can only partially know, but that sort of guides us. I believe we've got to stop very soon. And I'm not sure if we're going to be suddenly cut off, but just in case we are, could I just say thank you to everyone, to Chris for chairing, and for all 3 of the speakers for their help and their support for the book. Thank you. And to everyone who's attended. And now I suggest, would you others like to speak? And if we are suddenly cut off, well, were you going to say something, Rosa?
Yes, I just wanted to add to what you were saying, that what I found extremely useful with critical realism is that it enabled me to explain and not only to describe what I saw was happening in the units. And you were mentioning about the truth, and I think, for example, for me, the fact that in my interviews, the healthcare professionals constantly said how much they worried and they cared for the babies. And then when I came in and my observations didn't relate to that, and I could have said that is not true. They don't care for the babies, because if they cared, they would do more to bring the parents in. But then looking at the reality, you can see it is true, but there are different mechanisms, there are underlying forces, and there are problems that are causing these events to happen in the way they are. It doesn't mean that healthcare professionals are not caring. And you can see as well how they cared when working in the conditions that they worked, for example, and they didn't give up.
Yeah. Would you like to say something, Brenda, about?
Yes, I wanted to say that the book itself, I've read it, from the beginning to the end. Thank you very much. It's accessible, as you indicated at the beginning. What I found really valuable for me was when I first started critical realism, I was very overwhelmed with a lot of the philosophical side of stuff. But this particular book gives us a good introduction for anybody who's actually looking to get into critical realism as an introduction, as you say. And as well as the examples that we have, Rosa, your example, you've got your research there. There's a whole host of research from different doctoral students. So you've got the concepts that you introduced, as well as how doctoral students have actually introduced that. Now, I don't know about everybody else, but I learned by actually seeing how things are done, and those examples were a great insight to do. So I'd encourage anyone who's looking into this, and you probably know some concepts of critical realism, to get the book and try and see how the examples would help. So thank you so much for that, Priscilla.
Thank you. Since it's after 6, Chris, is that okay if I just close the session and say?
I hope my mic has come back on. Yes, please do close it, Priscilla.
Right. Well, thank you to all the speakers and to everyone, and for your nice messages on the Q&A. Thank you very, very much. And maybe we'll be meeting up again together, really, or on Zoom for future critical realism events. Okay. Goodbye, everybody, and thanks.
Thank you. Bye.
Bye.